this meeting as the Health and Wellbeing Board. I would like to inform those present that this meeting is being webcast live and will be capable of repeated viewing. It may be worth explaining that voting members, including health partners, are in attendance in the chamber to take part in the debate and to make decisions. Some officers and partners may be joining the meeting via Microsoft Teams. Are any members in attendance as substitutes today? Okay. Do any members wish to declare any interest in relation to any matters included in the agenda? We have no part 2 items today, so the press and public won't be excluded. Does the board agree to approve the minutes of the meeting on the 22nd of July 2025 as a correct record? Okay, thank you. This is the last Health and Wellbeing Board meeting that Stephen Lightfoot will be attending as chair of NHS Sussex Integrated Care Board. And he is retiring on the 30th of September. So I would like to thank Stephen very much for your attendance to the board and for all your good work and positive contribution towards the board work and focus on improving our population health. Thank you. We are looking at 4 issues today. We had a report on the city pharmaceutical needs assessment at our last meeting, and the final pharmaceutical needs assessment is presented today for the board to agree. We also have a report on implementation of the local joint health and wellbeing strategy. The board regularly considers reports that set out how we are performing in terms of delivering our strategic priorities. And today we will be focusing on the dying well domain. In addition, we have an update on progress on implementing Let's Get Moving, our sport and physical activity strategy. This update was requested by the board when we initially considered the strategy in March last year. Finally, we have a presentation of the development of the council's homelessness and rough sleeping strategy. A draft strategy is currently out for consultation, and we wanted to bring this to board members' attention as homelessness is such an important issue for partners across the city. I also wanted to make members aware that we have a council by-election this Thursday, and today's meeting is taking place in the official pre-election period. We are permitted to hold council meetings in the pre-election period, but we have to be even more careful than usual that we don't use them to say anything that could be taken as supporting a particular political group. I would ask board members to have regard to this when speaking today. The Democratic Services Officer will now undertake a call over items 18 to 22, and I ask that members indicate those items they wish reserved for discussion by calling them as appropriate.
Hi. So items today, item 18, update from the NHS Sussex Integrated Care Board. Item 19, sports and physical activity strategy update. Item 20, homeless and rough sleeping strategy. Item 21, pharmaceutical needs assessment, final report. And item 22, Joint Health and Wellbeing Strategy, Dying Well. Thank you. I can confirm that all items have been called.
Thank you. The next item is public involvement. We have a deputation today, and I would like to call on Mr. Keith Birchfield to present his deputation. Mr. Birchfield, you will have 5 minutes to present to the board. After you present your deputation, I'll read out a brief response. Please note that a deputation offers an opportunity for local residents to express their views on an issue, but it is not a debate. So there will not be an opportunity for further comments or questions here today. You can start. You have 5 minutes.
Thank you. Chair, members of the board, we are a group of concerned Brighton and Hove residents, including parents directly affected by the issues raised in this deputation. On the 15th of August 2025, the New Statesman published an extensive investigation into the prescribing practices of the Hove Wellbeing Clinic and the failures of NHS Sussex and NHS England to act upon repeated warnings over a 5-year period. These revelations are deeply troubling and demand urgent scrutiny. The New Statesman reported that in April this year, NHS England formally instructed Wellbeing to cease prescribing cross-sex hormones to under 18s, citing, I quote, indications that patient harm may have occurred. A joint investigation with NHS Sussex was announced in June. It also reported that regulators, including the General Medical Council and NHS England, had been aware of concerns since at least 2020. While official records show that as of May 2025, up to 139 children, some under 13, were in receipt of either hormones or puberty blockers through Wellbeing. It is reported that the model of care followed by Wellbeing, based on, I quote, informed consent, dispenses with psychiatric assessment and treats the child as the sole authority on their condition. The New Statesman reports that despite multiple complaints to the GMC, including one where a 16-year-old forged parental consent to obtain a prescription, no action was taken. The New Statesman reported that expert clinicians have issued stark warnings. Professor Kaitiala of Finland stated the use of exogenous hormones, I quote, is not safe to any minors. And that, again, in quotes, having reached age 16 makes no difference. Professor Dahlgren of Sweden explained that early hormone use carries significant risks of cardiovascular disease, infertility, liver damage, and cancer, concluding that the body and brain are, in quotes, permanently marked by such treatment. Sweden no longer recommends hormones for under 18s. Despite this, children, including some as young as 13, remain on prescriptions because it is alleged that NHS Sussex diluted NHS England's directive restricting only new patients from initiating treatment. In July 2023, the leader of Brighton Hove City Council dismissed parental safeguarding concerns. In October 2024, Brighton families warned the council's trans inclusion schools toolkit sidelines parents and allows third sector groups undue influence over vulnerable children. Legal experts have cautioned that the council's trans inclusion schools toolkit may expose schools to legal challenge for inadequate safeguarding and possible human rights breaches. Brighton Families believes this document has direct impacts on families locally in relation to the work of this board, as it establishes key service delivery principles for this council and the same third sector providers used by Sussex NHS. Chair, members, public bodies are bound by the Nolan principles of integrity, accountability, and transparency. When it comes to children, the standard must be higher still. Safeguarding must always take priority. I speak as one of the parents affected. This is not safeguarding. It is ideology overriding evidence, clinical caution, and parental responsibility. Children are at risk. We ask the board to acknowledge this reality and ensure that statutory safeguarding is recognised in active policy in this city by publicly calling for the desktop review, due to take 4 to 5 weeks, as noted in the terms of reference, children and young people offered gender care at the Wellbeing General Practice Brighton, section 5.1, published by Sussex ICB on the 22nd of July 2025, to begin without further delay. Thank you.
Thank you. Thank you for bringing this deputation to the board. We acknowledge your concerns and we take our safeguarding responsibilities seriously, working closely with local adult and children safeguarding boards. There is currently a live ongoing investigation into the issues you have mentioned, led by NHS England and NHS Sussex. I have asked NHS Sussex to comment on your deputation, and they have asked me to read out a statement. This is an independent patient safety investigation into prescribing for gender dysphoria for children and young people under the age of 18 at Wellbeing. The investigation follows concerns raised about prescribing that may fall outside of national clinical policy and guidance, which are based on the best available evidence. We are working with NHS England and have launched a rapid investigation into this care to determine the most appropriate support and treatment for these individuals' patients going forward. The investigation is being conducted by independent clinicians. The terms of reference for the investigation are clear regarding the safeguarding duties that may be required, and Sussex Integrated Care Board is working as fast as possible to initiate the review. We are very aware there are strong opinions and concerns from both perspectives on this issue, and have published as much information about the investigation as is possible on our website. We will update this page when more information can be shared. Next item on the agenda is members' involvement. There are no questions from members. And then we'll have, I'll invite Stephen Lightfoot, the chair of Integrated Care Board, to update us on Sussex update on the NHS Sussex Integrated Care Board.
Well, thank you very much, Chair, and thank you for the opportunity to provide an update following my paper on the ongoing NHS reforms that I described at our last Health and Wellbeing Board. Now, since we last met just before the summer, the government has confirmed in Parliament now, in the beginning of September, that a new NHS Sussex and Surrey Integrated Care Board will be established from the 1st of April 2026. This will cover the 3 million people who live in Brighton and Hove, East Sussex, West Sussex, and the county of Surrey. And this new area will be coterminous with the two proposed combined mayoral authorities in Sussex and Surrey as well. The first step has been taken, and that is the appointment of Ian Smith as the new chair for the new larger Integrated Care Board. Ian is currently the chair of the Surrey Heartlands Integrated Care Board, and I've been working closely with Ian in recent months in advance of my own retirement, as the chair mentioned, at the end of this month. The next decision will be the appointment of the chief executive, which we hope will be completed by the end of September, so that the new board in common across both Integrated Care Boards can then be appointed in the month of October. I just want to bring to your attention, this is still a very anxious and uncertain time for our staff, and we're providing as much practical support as we can for them in the circumstances. But it's become quite clear that the original timescale of reducing our ICB running costs by 50% by the end of this calendar year is now likely to be delayed due to next year due to the lack of national funding for the redundancies that will result. Now, on a more positive note, I am pleased to say there's a lot of commitment and energy to deliver new neighbourhood health services at or close to where people live, in both Surrey and in Sussex, to achieve the shift from hospital to community, which is a key component of the recently published 10-year health plan. Now, Surrey has a slightly different model of integrated neighbourhood teams built around populations of 30 to 50,000 people, whereas our Sussex model of 13 integrated community teams is built around the current district, borough and unitary council footprints. Now, I'm pleased to say that our NHS clinical leaders and wider stakeholders across the voluntary sector and the local government have developed a care model for our 13 integrated community teams. And this, along with the NHS Sussex commissioning intentions for the next year and the population outcomes we're looking to achieve, will both be presented to the NHS Sussex board in public next Wednesday for approval. Now, I think it's fair to say, as far as neighbourhood health is concerned, our first ambition is to provide coordinated, proactive care for people with multiple complex needs, those who are frail or near the end of life, or people with particularly complex needs who use our services a lot. And that's probably about 10% of the total population. We then want to extend the service to provide more continuity of care for people with long-term physical or mental health conditions. And that, again, could then expand the population to about 25% of the total. The third tranche is then to provide out-of-hospital urgent care for more people, because we're really critically aware that less than half of the people attending our accident and emergency departments need to be admitted and stay in hospital for treatment, which again would suggest that they're not in the right care setting, and we can provide better out-of-hospital urgent care to meet their needs, and that's the ambition. And then finally, the integrated community teams want to provide preventative care for the whole population, with things like vaccinations, screening and health checks, to name but a few. So I think in summary, my paper confirms that the reform of the NHS and the Integrated Care Board is ongoing, admittedly at a slower rate than originally expected. But our focus on delivering neighbourhood health services remains, and we're going to continue to do that to deliver our strategy of improving lives together. So it's a short update, but I thought it was important to keep the board fully informed of the latest status, and I'm very happy to answer any questions that there may be from that. Thank you very much, Chair.
Do we have any questions or comments? Please.
Thank you, Chair. First of all, I just want to place on record our appreciation of Bert Stevens' time in the role as chair of the ICB in Sussex. Myself and other sector colleagues have commented in advance of today's meeting that we found you to be approachable and honest, and really sort of fronted up in regards to some challenging scenarios that we faced in partnership together. So we appreciate your time and wish you all the best in retirement. And my question is about the new chair of the larger ICB under this Surrey and Sussex footprint, and whether you foresee they will be able to have the capacity to continue to engage in forums like this, which I see as having ever more increased importance when we consider the local needs of Brighton and Hove as a city, as we are going to be operating under a larger ICB footprint.
Well, first of all, thank you very much for your kind comments. They're genuinely appreciated, and I've always felt that the voluntary sector was a really important partner in our system, and I hope that you felt that, because that was always my intent. Obviously, I'm working really closely with Ian at the moment, and we're going through all of the commitments that I've currently got, because as I currently stand, I am a member of all 3 health and wellbeing boards in Sussex. I'm also a member of all 3 economic growth boards, a member of the Assembly, and a variety of other things. And so we're putting a list together of all the commitments, because Ian has also got commitments he's had in the Surrey system. I think I can't say whether Ian will be personally involved in every single one of the forums, but I'm very confident that the Integrated Care Board will be. in some way, because I think it is vitally important. And all the way through the changes, we've been very key, it's been very important to us to ensure that place, which respects the unitary authorities that will exist across the Surrey and Sussex, are well respected and will be represented. So I'm hoping that there'll be senior managers in any new organisational structure that will have a responsibility for each of the places. Now, that's currently 3. It may or may not be more in Sussex. It looks likely there'll be 2 in Surrey. So, but we're intending to make sure that the Integrated Care Board can be and will continue to be an important member of each of the health and wellbeing boards in the future. I just can't say exactly who will be the member.
Thank you. Any more questions? Yes, please.
Thank you for your presentation. I would like to ask you, how will Sussex ICB work with local authorities and community partners under the new devolution framework to address health inequalities, to ensure that funding decisions reflect the specific needs of our local population, especially deprived and marginalized communities?
Well, I think that's a very important question, and I think we'll continue. The new Integrated Care Board will continue as the current Integrated Care Board has been doing, to be involved through the Sussex Health and Care Assembly. We have a number of executive forums as well, whereby we work very closely with our local government colleagues, and health inequalities has been one of the key components of our priorities. That's what our Improving Lives Together strategy is all about trying to resolve. The delivery vehicle for that, I think, will be through integrated community teams, and there will be one integrated community team for Brighton and Hove. We've got a good population health profile, and actually what we're looking to do through our commissioning intentions is to differentially resource those integrated community teams depending on the need in those populations. So the more deprived areas should get more money, and other areas need to make sure we have a good and safe service as well. So, but we're looking to make sure that we reflect the population need, because the population needs even across Brighton are different depending on different parts of the city, but they're also very different to the needs in Chichester or Horsham or Crawley or Eastbourne or Hastings. And so we want to make sure the integrated community teams can respect and reflect the population need in each of those communities.
Thank you. Yes, a question? Hello? Yes, please.
Thank you, Chair. Just want to start by apologising for not being in there. I'm recovering from a viral infection at the moment, so I'm unable to attend. And secondly, I'd like to echo the sentiments to Stephen, to say my personal thanks for your support of Healthwatch and for the way in which you've openly included all members of the partnership, Stephen, in discussions. I think it's been exemplary. So thank you, and I also wish you well in your retirement. My question relates to the strategic commissioning role that the ICB will take on, and its core function, obviously, around population insights, patient experience, etc. Clearly, with the loss of Healthwatch in the future and the shrinking workforce across the ICB, I suppose my concern is how that role is going to be met, whether it be the staff, the resources, the skill set, and the approach the ICB will take to actually ensuring that the patient voice is embedded and not lost. So I just wondered if you could say anything about that, Stephen. Thank you.
Again, thank you, Alan, for your very kind comments as well. Again, as with the voluntary sector, Healthwatch have been important partners on our journey of developing our Improving Lives Together strategy, and we really appreciate the support. We also appreciate the tough love of hearing what our patients and residents think about the services, and that is vital for us to move forward. We're going to be reviewing our commissioning intentions, strategic commissioning intentions for 26-27 at our board in public next week. And there is a section in those following our stakeholder engagement, of which some of your colleagues have been involved, Alan, while you were ill, where we're looking to commission from the voluntary sector, and I think there's further discussion on who that exactly is, but we want to commission a service to make sure the voice of the public continues to be heard. And because I think actually there isn't necessarily the resource within the Integrated Care Board, you're quite right. But also, I don't think it's right that we should be marking our own homework. And I think you needed a level of independence. And what Healthwatch has brought to this is an independent voice of the patients and the public. And I think we need to retain that in some shape or form. So we very much want to work with, to collaborate exactly what that looks like. But we see that being provided through the voluntary sector in its broader sense, and obviously continue to work with Healthwatch while it continues to exist in its current form.
Thank you. Any more questions? Comments? Are members happy to move this update? Thank you. Item number 19, this Let's Get Moving, Brighton and Hove Sports and Physical Activity Strategy Update. I would like to invite Katie Cumming, Consultant in Public Health, and Verena Quinn, Healthy Lifestyles Manager, to present the report, please.
Thank you. We could have the first slide, please. Thank you. So we've, as was introduced, we've come along today to report back on year one of our Let's Get Moving physical activity strategy. The strategy was brought here to the Health and Wellbeing Board a couple of times during its development and then for signing off. And as mentioned earlier, there was a request that we come back, which we're very happy to do. The next slide, please. So our vision is for Brighton and Hove as a city to be somewhere where everyone has the opportunity, the encouragement and the environment to move more, live well and be healthy. And as we've discussed along the way, we had a vision for Brighton and Hove to be one of the nation's most active cities. And we were totally delighted that as it took us a bit longer than initially anticipated to develop the strategy, as we launched it that first year, we did find out that the stats were showing we were one of the most active cities in the country. We'll come back to those stats in a moment. Next slide, please. So this slide, those of you who've heard discussions around our physical activity strategy may well recognise this. This is our plan on a page. You can see the 5 coloured diamond shapes across the middle. So they're the sort of pillars or themes around which the strategy is built: active culture, active people, active communities, active environments and active systems. And those are based on the WHO themes for their physical activity strategy. Below them in the white diamonds, you can see key areas of work and objectives which help drive us towards our goal of an active city. This is very much a strategy that's based on reducing inactivity and addressing inequality. And we've taken a life course approach from pregnancy and early years right through to old age. It's all about supporting people across the city, more people to move more every day. And you can see along the right-hand side the outcomes, which the top 2 of the Health and Wellbeing Board you'll recognise as being particularly important. We know that being more physically active and less physically inactive improves our physical health and mental well-being. But there are also very significant benefits for us as a city. If we have a more physically active workforce, we reduce sickness absence, we've got a more productive workforce, and it's got real benefits for our place and for our economy. We know that more physical activity empowers individuals, but also empowers communities and has a real effect on every corner of our city. We also know that here, particularly in Brighton and Hove, quite a bit of our physical activity comes from travelling actively every day, and our stats support that. We know that not only does that contribute to health and wellbeing, our economy, but it's also a cornerstone of our net zero approach and helps us to be a more sustainable city. Next slide, please. So this just shows the trend in terms of our data. The latest OHID data, which comes from the Active Lives Survey, shows that for Brighton and Hove, which is those little green dots, there, we have got a very physically active adult population. Almost 80% of adults in Brighton and Hove are physically active, and that means that they are physically active for 150 minutes a week. Very slight decrease over the last 12 months, but not statistically significant. And compared to other local authority areas across the country, we're second highest after West Berkshire. So certainly something to be proud of, although we know with our focus on inequalities and equalities that there's a lot of variation behind that headline result. Next slide, please. Probably most important in terms of impact on health and well-being is physical inactivity. And this graph shows again the black dots at the top are the national data. And again, in a positive way, the green dots below it show that we've got a significantly lower proportion of our adult population who are physically inactive. Again, compared to other local authority areas around the country, we're absolutely one of the lowest levels of inactivity, the fourth lowest at present. So that really is excellent. And if we can home in with the data and our local insights on the communities and particular groups who still are more inactive than others, then hopefully we can achieve even greater health gains. Next slide, please.
Okay, Giles, if you don't mind just clicking on the infogram at the top there. We shared the infogram with you ahead of today. It's obviously quite a challenge to capture 20 objectives, but as Katie mentioned, there are 5 key themes. In total, 20 objectives across the life course of the strategy with clear indicators of success. And what we've tried to do within that infogram is to capture quantitative data where applicable, alongside storytelling and qualitative data as well. And it takes you across the course of every objective and hopefully gives you some really insightful case studies across the system. I think it's really important to emphasise that this is a whole systems approach to physical activity in sport. So these are not council-owned success stories. This is very much about partnership working, and as part of the infrastructure to support the strategy's delivery, we have a Let's Get Moving strategic partnership, and that is underpinned by 4 subgroups. We have a Children and Young People's Alliance, an Active Ageing Alliance, a Club Development Network, and also an Active Environments Alliance. So in total, over 80 organisations so far engaged in helping deliver the strategy, and over 200 stakeholders, which for the first 12 months is a fantastic achievement and something we're really proud of. If it's a problem, Giles, it's okay. I can move on to the next slide and people can look at it. No problem, that's absolutely fine. I can go on to the next slide and I'm sure everyone can have a look at the infogram in their own time. So for us in the year ahead, we've got some large ambitions. We want to bring all stakeholders across Let's Get Moving into one room. We think there's real strength in cross-pollinating the networks and obviously creating that connection across the city. We are the proud hosts of the Women's Rugby World Cup, and our team are responsible for that, supporting that legacy programme. So we have until March 2026 to deliver that, and that's a key area of focus for us. Workforce development is setting the foundations for what we hope will be obviously the next 9 years left in the strategy. So we are working with Active Sussex and have had some training around active medicine. And we're also looking at coordinating some physical activity clinical champion training as well. So really starting to work through primary care settings. Communication is really key for us. People in the room may have heard of We Are Undefeatable, which is a national campaign supporting those on long-term health conditions and just having a great big conversation about the benefits of moving more. And that's something we want to bring to Brighton and Hove and create a localised version of that campaign. We also have a 12-month Let's Get Moving campaign, which we hope will support some of our larger events such as Take Part. Some of you may be familiar, we have Take Part Festival every year, and in the last year over 4,000 people attended that and attended various taster sessions and engaged in the community about how to move more. So that's something, and that momentum is something we want to build upon in the year ahead. And also as part of our policy planning, we're also working with the planning team to embed the Sport England active design principles in the city plan review. So this is very much about working across the system and laying some of the strong foundations for the years ahead. If anyone's got any questions, I'm happy to take them.
And what I would say, definitely have a look at the infographic. It is really lovely and interactive. And sorry, the tech didn't quite work just now. Please do.
All right. Thank you for your report. Any questions? Lucy?
Thank you, Chair, and thank you for that report. Just wanted to just dig in, because this is my first time here, so it might have been answered in the past. But how exactly do you collect that data? So you're saying we're the second highest in the country, but how exactly are you collecting that data? How are you thinking about the disadvantaged in this city, whether that might be sort of financially disadvantaged, whether we might be looking at mentally or physically disabled, making sure they are being active. And the other one is just being a teacher. When you're collecting the data on the children, are you including like school-based sports in that data as well? Thank you.
So the data that we were talking about, those graphs, the adult data, that's a national survey. So that's active. It's called Active Lives Survey data, and it's collected across the country. And it's repeated every year. So that's a national methodology. We also have, we haven't touched on it here, but we do report it elsewhere, some other fantastic sources of data about physical activity and inactivity. And some of that data very much is, as you're alluding to, dives into those groups who might find it a lot harder to be active. So those with physical disabilities, those with health conditions, all sorts of different barriers to being more active. So you've had here at the Health and Wellbeing Board, and I realise you may not have been here at the time, but recently the Health Counts survey data has been presented. So that's a once in 10 years, absolutely fantastic source of data for our adult population. The information around activity and physical inactivity provides a wealth of information about different geographical areas, levels of physical activity and inactivity, but lots and lots of information about all of those different factors in our local population that may make it more or less easy to be active or inactive. So we do use all of that information. We also use information collected from communities, from neighbourhoods, and some of the information that went into this physical activity strategy was stakeholder consultation, which was a combination of a survey, but also focus groups and very sort of proactive going out to people who find it harder to be active. For children, we have the Safe and Well at School survey, another survey that gets reported back here to the Health and Wellbeing Board. And that survey it goes out to all primary and secondary school age children in the city. And the not this very latest one that's happening this year, but the previous one had a deeper dive into physical activity, some absolutely fantastic data, not just around levels of physical activity and inactivity, but some really insightful information around the barriers, everything from, the things that might make boys or girls not want to do PE or sport or to be active, down to things that would make it easier. Really fantastic data. We're really happy to share that again in the wake of today.
Yeah, I guess just to add to that as well, we also have a long-established school games programme as well, which we follow a kind of established roadmap and have our own kind of service level data in terms of children and young people. And picking up on your point on those disadvantaged groups, when we published the strategy last year, there was an equalities impact assessment that accompanied that. So a lot of the work that's running in the background is a lot of targeted programs, and lived experience is very much at the heart, especially in the last 12 months of some of the work that the team and other partners have been doing. So, for example, we did a This Girl Can Be Inspired event and had about 80 Year 9 and 10 girls talk to us about their barriers to participating in PE, which then led to us presenting Let's Get Moving at a school leaders conference and some tangible changes in relation to PE, changing facilities and PE kits and so on. So it's very much an ongoing engagement. We had 800 people give us their opinions as part of Let's Talk Active for Life. But it's very much a live conversation about targeted groups and finding out what their barriers and the opportunities are for us to address some of those challenges in the community.
And I would say as well, because you mentioned the We're Undefeatable campaign, and because that's focused on people with long-term conditions, we had our Active Ageing Alliance annual workshop last week, and again, just heard really fantastic, informative and moving lived experience accounts from people who came along and told us exactly how they like to be active. These are people with significant physical barriers to being active, but for our next stage, that's absolutely a focus.
Thank you, and thank you, Councillor Halwang, for your question. Any more questions or comments? Yes, sir.
Thank you, Caroline. It is also data related, my question. During my mayoral period, I have participated in 2-3 events with take a part and also within stadium. My question is how successful we have been in the past year in terms of encouraging people in the cities, communities, including people from different ethnic and faith backgrounds, and more deprived area and more physical activities. Thank you.
I'll make a start now. So in terms of Take Part, which I referenced earlier, is our annual 2-week festival in relation to physical activity. And the difference that happened with Take Part last year is that alongside a large scale event at the level, we also did Take Part local and took it out into local communities through Hangleton and Knoll, Old Boat and Cruise Club, and we went out into the actual communities. So to make it a lot more localised and place-based. There's been, and there are some case studies in the infogram that you'll see around some targeted work that we've done with Multicultural Women's Group around swimming confidence, and we've worked with partners to run short courses. And again, just listen to what people were saying and us are their barriers and trying to unblock those. I think we recognise that that's an ongoing conversation and dialogue with various groups over the course of the strategy, as we just said. So I think we've made some starts and initial conversations with specific groups, and we're definitely looking at our stakeholders across the system and across our subgroups to make sure we've got the right people around the table to help support that work. But I think targeted programmes and lived experiences is very much at the forefront of our direction of travel. So that's absolutely where we're going. Yep.
Thank you, and thank you, Councillor Zaman. Any more questions? Yes, please.
I think my colleagues on the right have already asked my largely the questions I'm going to ask, but I think it's really good. I think this is a fantastic programme. So first of all, just well done, and it's really good to see. I saw it's coming through the early development phases. Becoming real is very important. I think showing national data for all adults is fine. And it's a national survey, so it's a robust source. But I think actually, because you've got the different subgroups already set up, I think actually having specific data for children and then a target of what we want to achieve. Similarly, I think with the ageing well group as well, I think I would the over 65s or whichever group I now fall in. So certainly I think is important there as well. And again, have some data on that and then set a target. Because I think it's not just about analysing the past, it's about looking forward as well, is what I would strongly recommend you to do. But I think it's a brilliant programme, and I just encourage you to keep going down this route because it's great.
Thank you. That was very important for contribution, and thanks.
Alan Boyd's got his hand up on the screen.
All right. So do you have another question, Alan? Would you like to ask a question?
Yes, thank you. Sorry, I'm behind you. You probably can't see me. So I just wanted to echo Stephen's sentiments. I think it's a really important programme, and just a piece of work we've done recently on looking at hypertension, working with TDC, Bridging Change and Switchboard and Brighton Unemployed Families Centre. For those who don't know, hypertension is one of the leading causes of premature death. So we were looking at barriers around that, and the way this just shows how everything is interlinked and why integration is so important. Because when we spoke to people around how they manage their hypertension, quite a few of the people we spoke to who were from areas of higher deprivation talked about the value of free and low cost community exercise classes. So I mean, this work might just seem like a strategy on the page, but actually in the community it's really supporting people to potentially lengthen their lives and live in slightly healthy lives as well. So I think it's a really important strategy and plan. It's really good to see these updates as well. I'd like to see more of these annual updates coming to the board, I think. I just had a question really around what seems to be a decrease in children and young people being active for over an hour a day. It seems to be lower than it was back in 2021. It seems that that's a real area of focus for us. So I just wondered if you could comment on that, please.
Yeah, we are aware of the slight decrease in terms of the children and young people. I think in terms of I guess our response to that, as Katie mentioned, we have the Safe and Well at School survey. We've also do a lot of work through school settings through our school games network and with various leaders across schools in general, across primary and secondary. I think for us, it is that lived experience focus. So in the last 12 months, for example, we've recruited youth active champions to the programme to again find out a little bit more about some of the opportunities there might be to work with young people in the city to address some of their barriers to moving more. But I think for us, it is about kind of addressing some of the systems working, which we've tried to do through kind of working with PE teachers and raising the profile of Let's Get Moving, heads and so on. And I think for us adopting and continuing to adopt a place-based approach, we have a community-facing programme through Active for Life, which offers free and low-cost activities for children and young people. So I think for us, it's about strengthening the offer of what we're currently providing and looking at any gaps that there might be in specific communities and seeking to address those going forward.
Yeah, I haven't really got anything to add other than, yeah, as Verena says, I think data-wise, we know that the Active Lives survey is a big survey, it's nationally comparable, but the sample size isn't huge, so it's useful. But we know if we want to really sort of delve down into the detail, our local surveys are really, really useful. And particularly with the Safe and Well at School survey, we've got the fantastic ability to look sort of across various different areas of activity. So we can look at, children and young people who are more physically active and look at their mental well-being as well. We can look at children and young people who've said that they travel actively to school and how that contributes to their physical activity levels. So there's all sorts of different additional ways that we can work in the community, but also through our school games programme with schools to try and improve levels of physical activity for everyone, but particularly for those that we're worried are least active.
Okay. Thank you, Alan, for your question, and thank you for your clarification. Any more questions, please? Any questions, any comments? No? All right. Does the board agree to note this report? Thank you.
Great.
Yeah.
Struggling to find a receptor for the next item. It's in the building somewhere, but we're going to go and find it.
All right. Okay, we'll take a break for 5 minutes. Then we'll continue. Next item on the agenda, which is homelessness and rough sleeping strategy 2025 to 2030. Today we are presented with the draft homelessness and rough sleeping strategy 2025 to 2030 for information only, in line with pre-election guidance due to the upcoming Queen's Park by-election. Board members are encouraged to engage with the ongoing consultation and provide feedback via an online survey. I would like to invite Harry Williams, Brighton and Hove City Council Director of Housing, People Services, to introduce the report. Harry, please.
Thank you, Chair. I'm just going to share my screen now, and hopefully board members can see the presentation coming up on the screen. Hello, everybody. As introduced, I'm Harry Williams. I'm Director of Housing and People Services at Brighton Hove City Council. I'm here this evening to talk about our draft homelessness and rough sleeping strategy and the consultation that we're currently running on our draft strategy. So just to provide a little bit of context before we start talking about the strategy itself. So the City Council has a legal duty to review homelessness and develop a strategy every 5 years. Our current strategy expires at the end of this calendar year, and we're of course working to develop our new one for the next 5 years. Our strategy meets or is aligned to our ambitions as a local authority to create a better Brighton and Hove for all, and delivering specifically homes for everyone outlined within our housing strategy. We're not the only ones developing a strategy. There is a national homelessness and rough sleeping strategy that's being developed at the moment, and we're anticipating it to be released or published towards the end of this calendar year, towards the end of 2025. We're not entirely sure what that looks like just yet, but we've got a real indication that it's going to be focusing on the prevention of homelessness and rough sleeping, and really encouraging a cross-government departmental approach in addressing some of the issues that drive homelessness and rough sleeping across the country. We're also developing our strategy, or have developed our strategy in the context of increasing financial pressure for the local authority, and we're expected to spend around 14 million on temporary accommodation costs alone this financial year. We're also anticipating reduction in what we call our homelessness prevention grant, which is a grant from central government that we use to carry out activities to prevent people from experiencing homelessness, but also provide support once homeless, and also to cover some of the costs of temporary accommodation. And we're anticipating a reduction of that of up to 4.9 million, which equates to about 44% of our overall grant allocation. So we're developing and delivering the strategy in an incredibly uncertain financial context, which presents its challenges in itself. So just to talk a little bit about our review. So to inform our draft strategy, we carried out a review of homelessness and rough sleeping in the city over the past 5 years. And in carrying out that review, we really asked for support and information from partners across the system, and carried out a call for evidence, which involved a number of partners and some of board members' organisations here today. During the review process, we identified research from Shelter, and in June 2024, Shelter estimated that on average about 3,500 people experience homelessness in the city, equating to 1 in every 77 residents of Brighton and Hove. Around 40% of those experiencing homelessness were children. And that rise of children experiencing homelessness is being reflected nationally, and there's a lot of emerging research at the moment about the longer term disadvantages and health inequalities of children growing up in temporary accommodation, as well as adults as well. Our last street count identified 60 people sleeping rough, plus a number of unknown people living in an insecure accommodation, such as sofa surfing. So a number of rough sleepers within the city is increasing, and again in line with national trends. And some of the data there just paints a bit of a picture about the demand on the council's homelessness service. But more importantly, I think to highlight to the board is that in early 2025, our data show that at 704 people experiencing homelessness, had 2 or more compounding needs in addition to homelessness. So that includes things like mental health, domestic violence, substance misuse, or an offending history. Effectively, what we're seeing in the city is more and more people experiencing homelessness and rough sleeping with greater level of need and complexity. So just before I dive into what we're proposing in our strategy, I just wanted to talk a little bit about how we've gone about developing that strategy, which I think is really important. So as I mentioned, we have taken a real partnership-based approach in developing this, and we've engaged with a number of board members and their organisations early on in terms of supporting the development of our strategy. And we've really engaged the voluntary and community sector in providing evidence, ideas, and collaborating around developing our draft strategy. As I talked about, we're delivering our strategy in a really uncertain financial climate, and through this, we're really thinking about how we can sustain our services in the future in light of that reduced grant funding. We recognise that we really need to improve our prevention work. As a local authority and as a city, we're quite effective in preventing homelessness. Our data shows that outcomes for people experiencing homelessness or risk of homelessness, is really effective. What we're not so good at is getting to people early on, and we need a real focus on earlier intervention, or what we call upstream prevention, to prevent homelessness before it even occurs. We've developed our strategy with or alongside people with lived experience through an organisation called Common Ambition, who have been transformational and fundamental in helping us design our strategy, the language that we use, and the ideas that we're putting forward in the strategy. And I think really importantly for this board, we've really lent into the health and housing policy agenda and have really focused in on how, so the relationship and the connections between health and housing and the integration of different services. And really that's fed through the data that we've identified through the review and other work that's going along in the city in that health context. We know that people experiencing homelessness face significantly worse health outcomes. We know that people experiencing homelessness have higher rates of mental health issues, including depression and anxiety. We can see increased prevalence of substance misuse. There's also a greater likelihood of longer-term physical health conditions resulting from temporary homelessness and prolonged stays in temporary accommodation. Our health counts data has been able to identify what some of the prolonged impact of homelessness is having on our population, and we're really leaning into this in the strategy to better understand those health needs. Also think about how we can work with partners in a more joined up way to resolve those issues, but more also thinking about how housing has a role in preventing the escalation of health and care needs, and better collaboration provides real opportunity to improve health outcomes for people living within our city. Here is a slide of our proposed priorities outlined within the paper. I won't go into detail on each priority here, but really just the headlines for us are: no surprises that we really want to improve our effectiveness in preventing homelessness, and really that's around early intervention and looking at different ways that we can reach people earlier on to prevent homelessness from happening in the first instance. We also really understand and recognise our pressures around temporary accommodation, not only financial, but also just the health implications that I've just outlined. We want to improve our pathways and experiences of people living in temporary accommodation. And lastly, we really want to provide more joined up support with our partners to people who need it the most. And that's all the work that we do around multiple and complex needs, and also developing that and thinking about different ways that we can provide that joined up support for people experiencing homelessness, but also work with organisations in a better way who are working with people who are homeless or at risk of homelessness to see if we can support that early intervention as well. As part of the proposed strategy, or the draft strategy, we're proposing the introduction of something called a children, families and young people chapter. Really, this is a specific focus on that group of people, or their group of people, and recognising really the growing number of children that we have living in temporary accommodation, and also, as I mentioned, those longer term health inequalities as a result of it. We're, through the consultation period, working with a number of organisations that support children, family and young people to really help develop that children, family and young people chapter and the actions that we propose to take forward in the strategy. We're currently consulting on a strategy, and consultation ends on the 26th of October. We're aiming to take our draft strategy to City Council Cabinet in December for final approval, and hopefully by then we'll have a better indication about what the national strategy is looking like. But the consultation period is currently running to the 26th of October, and really encourage board members and their organisations to respond to our consultation. And you can do that online or by attending one of our consultation events. And there are a series of workshops being organised across the city with relevant organisations that would have been invited or will soon be invited to take part.
Thank you, Chair.
Thank you, Harry, for the report. Do we have any questions or comments? Yes, Stephen.
Well, first of all, thank you very much. This has been a huge piece of work, hasn't it? Just the sheer volume here. And obviously, working in the NHS, this is not my area of expertise, but I can see a real clarity about what you're trying to achieve. So I just wanted to make that particular point. But also because it's not my area of expertise, I may be going to make a stupid question here. But so please apologise for my ignorance. But I understand in terms of your vision and priorities about prevention, then about improving that temporary accommodation experience, and then clearly about providing joined up support. That all makes sense. But in terms of the joined up support, that's supporting people in a homeless situation or a temporary accommodation. I didn't really see too much around how you help people get out of temporary accommodation and into a more permanent residence. So I wondered if there was an opportunity to maybe expand on that. And then maybe one of the ideas would be around, and the linkage with health is excellent. So thank you for, again, engaging health partners. But I didn't see any real linkage with the Economic Growth Board. Now, I know a number of people who are homeless, as you rightly said, have got multiple compound needs, and so therefore wouldn't necessarily be an easy move into an employment situation. But I wonder whether for people who are maybe just recently homeless, there's still an opportunity to maybe help them find some form of employment as another form of that prevention. And there were just two thoughts. I'm sorry if they're really stupid questions, but they were just observations that I made when I read it. Thank you.
Thank you for that question. Carol, would you like to answer?
Thank you, Chair, and thank you for the questions. And they are very, very good questions, very good strategic questions. So the move on for temporary accommodation or movement through our homes is a really important part of the strategy. We're focusing in on that under that temporary accommodation pathways and experience piece, and what we can do to support people move through temporary accommodation and all the different partners that we can work with in the city to increase that supply of housing, but also supported housing and other forms of accommodation. But I think the comment around we just need to really make sure that we're focusing in on what we call the end goal. I think there's a real focus on dealing with immediate pressures of temporary accommodation, but really we want to be moving people out of homelessness, and we can't lose sight of that within the strategy. In terms of the unemployment point, you're absolutely right. So 60% of people experiencing homelessness in the city are either unemployed or not in full-time education or training. So there's that real need. And some of the feedback we've had through the consultation period already is about a need to engage with local businesses, for example, and we're taking that through in the consultation. Thank you.
Any other more questions? I think Daniel, do you want to answer? Yeah, I'll come first, Daniel. Yeah, I think you were before.
Thanks, Harry. And of course, we've been so integral in working with yourselves and your colleagues on the strategy. So it's good to see it come to fruition. And I suppose my comment is, and you mentioned it, is in the sort of prevention element. There's a lot we can do together, and the neighbourhood health teams and the MDTs. And you mentioned the multiple compound needs as one of our ICT footprint for the city. And I think there's a lot we can work on together, because it isn't on the fringe now where housing has such an impact on people's health and outcomes. It is in the middle of it. It is central and it's core. And as Stephen mentioned, amongst employment and other aspects is one of the main wider determinants of health, and in Brighton and Hove particularly. We know persons who are experiencing homelessness or on the cusp of experiencing homelessness will have multiple other factors, as you mentioned. And I was just thinking, and Adam may want to come in east of the city, obviously, there is some of the highest areas of deprivation. And I think one thing I was thinking of is in looking at people's needs, are we considering the multifactorial element? I know there's a shortage, obviously, for temporary accommodation. There's a lot of applications. I'm just wondering, in the spirit of looking at narrowing the gap of health inequalities and the longer term impact, whether there is any way of prioritizing or supporting that, or something to take away and think through. And then Adam, I was thinking the East Brighton Health Hub. I know we've got housing support in there. Is there anything else we can do on the prevention element to build into that? Maybe take it outside with Harry. Thank you.
Thank you, Tanya. And Any more questions? I guess that was just a contribution and comment. You don't have any other questions?
Yes, just a general. And Harry and I touch base quite often. So I think it was just something for Adam to mull over from a primary care element about how we work closer together.
Okay, thank you. Yes, can we have Councillor Halliwell? Yes, please.
Thank you, Chair, and thank you, Harry. Just a couple of things. Just digging slightly into this upstream intervention, and I'm sure across all different specialities, we know that early intervention is often more effective and cheaper. So it's always a good thing. But it's kind of, how are you trying to identify people who are going to be at risk of being homeless? And I know that a lot of our homeless issues are from private renters who are just finding that they can't afford the private rents that are being charged in this city these days. And the other thing is, does this strategy include people that are living in overcrowded households? So they're not technically homeless, but the conditions that they're living in are extremely poor due to that overcrowding. Thank you.
Thank you for your question.
Thank you, Chair, and thank you for the question. And it's a really good question about how we're going to identify people earlier on. And I think my answer to that is that we take a really data-led approach. So what we do is we look at the needs or support needs of people experiencing homelessness and try to identify their touch points with different organisations that they might be working with as a result of those needs. So, for example, if there's a physical health condition, they might be linked in with their GP. And what we do there is that we have been out to local healthcare services and saying, look, you'll be working with people who are at risk of homelessness. They might not be telling you about it, or they might not be telling us about it. But if you come across anyone who's at risk of homelessness, or if you start asking about people's housing situations, please let us know, and we can help provide that housing advice and support. The other thing that we're developing as part of our strategy is something called a predictive analytics model. Effectively, what that does is it pulls together all sorts of council data. So that could be things like council tax data, housing benefit data. You might have someone, for example, who has applied for a single person's discount for their council tax or other types of benefits within the organisation. And we pull all of that data together and try and understand what factors there might be for someone who's at risk of homelessness. And that allows us to intervene much earlier to be able to resolve that person's homelessness. So it's a bit of an emerging space that lots of other local authorities are working in. And there's some research that's going on nationally as well about how to use predictive analytics, for example, to predict someone who might become homeless and about how we intervene earlier. In terms of the overcrowding point, yes, absolutely, someone in that situation would be homeless. We apply a series of different legal tests. One of those tests is about whether or not if the accommodation that someone is in is suitable for them to continue to occupy. And if it's a seriously overcrowded situation, we would say that that's unreasonable and unsuitable. We'd want to work with that household, first of all, to try and prevent that homelessness from occurring, but we would be supporting those households.
Thank you.
Thank you. So the feedback I've got is from sector colleagues who've asked Tom and I to bring various points to the meeting. Firstly, the feedback is that I think the process of consultation and engagement throughout the development of the strategy has been really consistent and encouraging, and as a result of that, the document's accessible and compassionate, which is really good. There's a concern that despite the inclusion of a section related to children, young people and families, the unique challenges and needs of young people aged 16 to 25, who make up 20% of the homeless population, it's not clear how that's being addressed. I think there's references to children and people as part of a family, but much less so of young people as individuals. And despite the acknowledgement that the data related to young people is poor, we couldn't see anything like it, or be interested to know if there's a plan to improve that.
Thank you. Can you answer the question, please?
Thank you, Chair, and a good question. So I think, first of all, thank you for the feedback on developing the strategy. It's been really important to us that, whilst the local authority has that responsibility. This is a city strategy, and it's a system-wide issue that we really need to work together to resolve. The feedback that we've had from partners on our children's, families and young people chapter is really valid, and we've had that feedback before, and we're really thinking about it in the consultation period. Our plan is to have a separate or very specific workshop with all of the organisations working with children, families and young people to set out what actions are included within that chapter, and what we can do across a system to really support those groups of people. And I think what's going to be really important is about that data quality and data collecting as one of the key actions that we take away in that chapter to really improve the information that we have on young people. I think the justification for having that children, family and young people chapter is that they're also interconnected. We've talked about sort of the long-term effects of children growing up in temporary accommodation or unstable accommodation, and they're sometimes the young people that are accessing services later down the line and wanting to work in that more preventative type way. But it's a really valid concern, and we're really hearing that from the sector and taking that into consideration in the consultation.
Thank you. I think Alan was to ask a question. Alan, please.
Yeah, thank you, Chair, and thank you, Harry, for the presentation. And yeah, just to echo, the engagement is really strong. So yeah, thank you for doing that, putting the user voice at the heart of this. I just had two questions. One was, this is a citywide strategy, and I just wondered how much it reflects or speaks to the strategies of local authorities, not just in Sussex, but in surrounding areas, because our strategy is only going to be as successful as perhaps theirs, because people obviously move between geographies. And I just wondered if you could speak about that in any way. And the other thing was obviously the reference in the paper to the funding and the grants and whether they're going to be maintained going forward. It just makes me question, this is a very ambitious strategy, and I just wonder, is it completely realistic? What can we actually achieve if that funding really does, when funding restrictions do happen? Thank you.
Thank you. I think that's an important question. Harry, would you like to answer that?
Thank you, Chair. So just taking those in turn. We work very closely with other local authorities across the county, and have connections with other local housing authorities and things like the Emerging Supported Housing Regulation Act and other pieces of legislation that are coming down the line, and we really work in a connected way. That being said, I think Brighton and Hove has some quite unique challenges. So we have one of the largest single adult populations living in temporary accommodation nationally. We're a bit of an outlier in the number of people, a number of single adults with those complex needs living within our temporary accommodation. So whilst there are some opportunities, and we do work with our Pan Sussex colleagues, we do have some unique challenges that we're really focusing in on in our strategy. But we are very mindful of the fact that this is a 5-year strategy, that devolution will be coming up, and we just need to be thinking long term about what that Pan Sussex arrangement looks like in the future, specifically on things like commissioning of services and delivery of services locally. I think on the funding opportunities, make a really valid point. It is really challenging. I think lots of organisations, we try to invest in prevention services. We know that sometimes that can be difficult to justify in the first instance, and got to look at a sort of a long-term financial planning way. I think our thinking as a local authority is actually we do have quite a significant amount of funding investment into homelessness services. I talked at the beginning about that £14 million. We're expected to spend £14 million in temporary accommodation right at the beginning of the presentation. Through the strategy, what we're trying to do is channel that funding in different ways so that we're getting greater value for the money that we are spending on homelessness. So things like how can we use that funding with different providers, for example, of temporary accommodation that have wider benefits in supporting people resolve homelessness. How can we invest that money in different ways to increase supported housing, for example, or supported temporary accommodation? So they're really valid concerns, but I think for me, it's just about how we redirect our existing funding. But we really are in a really difficult financial position, and it's a system-wide approach, and really encouraging the support of partners across the piece in delivering the aims of the strategy.
Thank you. Any more questions, comments? Yes, Councillor.
Harry, thank you for your presentation. As because it is a health well-being meeting, so I would like to ask you, how can we integrate housing support into our health strategy so that preventing homelessness become part of improving overall public health outcomes? Thank you.
Thank you. It's the big question, I think, for me, and I guess in the spirit of the strategy, I think what we're really trying to move towards is that space of early intervention. And we know from our data that there's lots of people experiencing homelessness or might likely experience homelessness touching different health organisations. So there's something for me about how we work in a really connected way to make sure that when we're working with patients or other service users, we're asking questions around housing situations and really recognising the fact that those situations can escalate and someone might experience homelessness and refer to us early on. I think there's something around the commissioning of services, about how we join up in our commissioning of services to make sure that we're really recognising health outcomes in a housing perspective, but also housing outcomes from a health perspective. And I also think there's something about how we think about with the community teams, about how we work on a more place-based way to really support that prevention work. There's lots of opportunities within the strategy and really welcome board members' views on how they think we could work more together within that health and housing space as part of this process.
Thank you. Any more questions, comments? Does the board agree to note the report? Yeah, thank you. The next item on the agenda is pharmaceutical needs assessment final report. And I would like to invite Caroline Vaz instead of Kathy Hacker, who is unable to be here today, to present the report, please.
Thank you. Yes, apologies, Katie's unwell this evening. So you may remember that we brought the pharmaceutical needs assessment to the Health and Wellbeing Board a couple of months ago in its draft phase and received feedback on it. This is now the final report for the Health and Wellbeing Board to note, ready for its final sign-off at the beginning of October. So just as a reminder, the pharmaceutical needs assessment is a statutory duty of the Health and Wellbeing Board to refresh that needs assessment and undertake one every 3 years. And the aim is to understand the needs of the population of Brighton and Hove and also what the provision is with regards to pharmaceutical and pharmacy access. So we haven't identified any particular gaps now or in the future at the moment, and there's good access to services across Brighton and Hove. I think when we brought the P&A a couple of months ago, one of the queries was how was our access linked to or related to the national picture and whether there were national targets, and we were able to feedback to the board at a later point that there aren't specific targets. We're measured against the national average and we do well against the national average. So we have no particular concerns. We reported back on our consultation process at the last meeting and the responses we received. We've updated the document accordingly and the final document is now here for the Health and Wellbeing Board to sign off.
All right. The recommendation is that the board agrees the 2025 P&A. Does the board agree? Thank you. Okay, the last item on the agenda is joint health and wellbeing strategy outcome measures, dying well. I would like to invite David Brindley, Public Health Program Manager, to present the report, please.
Right hand button. There we are. Is that better? Okay, thank you, Chair. As you said, I'm David Brindley. I'm Public Health Programme Manager at the City Council. Tanya, are you going to join me or are you going to?
You'll come over, okay. But I'm also going to be joined a bit later by my colleague at the ICB, Tanya Brown-Griffiths, Director for Commissioning and Integrated Community Teams at Brighton and Hove. As the board will know, the health and wellbeing strategy was identified a number of outcomes that were reflected under 4 key areas and themes known as the WELLs. So starting well, living well, aging well and dying well. And this is an update for the board and an overview of work taking place in the dying well area. And we'll ask the board to note the sort of updates and services in place. Giles, have you got me slides?
Sorry.
Okay, if you go straight to the next one. Okay, so improving end-of-life care and helping people to die well and with dignity is important for everyone. This involves coordinated efforts across healthcare, social services and communities to meet the diverse needs of our population and focusing on maintaining well-being, social connections and personal preferences for care. Helping people to have choice and dignity at the end of their lives can't be delivered by one agency. The NHS plays a key role, as do hospices, charities and voluntary groups, and also the private sector, through workplaces and employment, having an ageing society. Local authorities also have an important role to play, both in the delivery and commissioning of key services, such as social care, information and advice, home cares, care homes, and also through their place-based leadership and through community inclusion and ensuring that services are accessible and tailored to the needs of individuals. Next slide, please. So there was one key outcome measure chosen by the board for this area, and that is the percentage of deaths that occur at home for all ages. And this is specifically people in their own home, not usual place of residence, so it doesn't include care homes. You're probably looking at it on the report, I'm sure, but otherwise it's up there. The bottom line on the left-hand side, the darker line is England, and the line above it, the faint line, is Brighton and Hove. The yellow dots mean we are similar to the England average, and the light blue mean we're better than. So you can see that for most years we've either been similar to or better than. We generally have more people dying at home than the England average. And when asked, people say, where would you like to die? They would nearly always say, in my own home. So on the face of it, it's a good thing, but we can't make assumptions because it doesn't always mean they've had a good death. Next slide, please. So this is a bit more data on place of death. Again, in 2023, which is the most recent data we have, 37% of deaths were in hospital compared to 43% in England, 32% at home compared to 28%, and 26% of deaths in care homes, which is a higher number than the England average. There is a fourth figure here, 1% of deaths were in a hospice compared to 5% in England. However, this is likely to be an underestimate because this data doesn't capture those that die at home or in a care home with the support of hospices. So hospice at home services are not included in this figure. There has also been some work done by the ICB looking at the numbers, and I think they would challenge, actually, there are more people under Margaret's care dying than are in this national figure, but that's what we have for now. People aged 85 or over were least likely to die in their own home, more likely to die either in a care home or in hospital. And for all age groups, except those aged 75 to 84, people in Brighton and Hove are significantly less likely to die in hospital than in other places. And the final bit of data there, as at March 2024, there were just under 1,000 patients on a GP practice palliative care register in Brighton and Hove. That's 0.3% of all patients compared to 0.5% in England. So somewhat to bring it up, but it may also reflect the fact that we have a younger population than a lot of other areas. So, that may explain why there are less on the palliative register. And being on that, it is a good thing because it will, it's about identifying people in the last year of life, getting them on a GP register and managing that whole kind of process of dying. Next slide, please. So this is just some of the work going on across the city under the 3 strategy objectives in dying well. There's a bit more in the report, but these are just some of the sort of highlights. So every year in May, Hospice UK run a national campaign, Dying Matters Awareness Week, and the Public Health and the Council's communications team and NHS Comms coordinate and promote events delivered by partners across the city to create an open culture in which we're comfortable talking about death, dying and grief. And just some of the activities that have taken place during those weeks include film screenings, we've had photo exhibitions, death bingo, where people explore different euphemisms that we use for death and dying. And at the Unitarian Church on New Road, there was a whole day of different faith leaders coming in and giving talks about the different approaches to death and dying that different faiths in the city have. So, often very interesting events happening during that week. We also have half-day training on the Learning Gateway called Preparing to Say Goodbye. And this is aimed at frontline workers and giving them the skills and a toolkit to navigate difficult and sensitive topics with the people that they're supporting. And that's mainly attended by social care staff, NHS, frontline workers, voluntary sector workers. And it's just that kind of trying to address that idea that, someone comes up to you and, they say, we're worried about death or dying or caring for someone, that people can then confidently have a guided conversation with that person and not sort of say, that will never happen. You'll live to 1,000,000, or live to 100, And that's been running for about 6 years now, actually, very successful and always full. We also have a monthly death cafe, although they don't describe it as that, but that's a model which takes place at the Cornerstone. And it's an opportunity and a safe space, again, to have conversations about death and dying and loss. And this is facilitated by a therapist and death doula, or soul midwife, is another way she describes herself. And the conversations can be anything really from, how do I put together a living will to, just kind of how do I deal with the grief that I'm feeling. But they're always guided. We also have the Aging Well partnership, and some of the partners are in the room, which is commissioned jointly by Public Health and the ICB. People who are bereaved in later life are at an increased risk of loneliness, social isolation, and a decline in their mental well-being. And Aging Well provides access to information and advice, social and health and well-being activities, and volunteering opportunities, keeping people who are bereaved engaged in their local communities and keeping them active and meeting new people. So addressing that loneliness and isolation. Next slide. And Tanya, this is the kind of ICB-led work. I don't know if you want to read through that. Yeah.
Thank you, David. And I'm really just going to introduce Helen, who's joined us to talk specifically about the Pan Sussex Palliative and End-of-Life Care Programme. That's a board that has oversight around the sort of death, dying, ensuring that the end-of-life care pathway, palliative care pathway is meeting the needs of our population. But mostly, I just wanted to touch on one thing before Helen joins, is that the sole concept of dying well is ensuring that our communities are responsive to the needs of our population, and that is where the neighbourhood health teams will really meet the community's needs, because level, it is really important to have an approach that is tailored to the communities at that locality. And there are many things that we know factor into what makes a good end of life care provision, but also ensures that person's culture, values, beliefs are respected, and the family supporting that individual is part of that decision making. And that's where the neighbourhood health teams will begin to work together, because that's about supporting population groups starting in the last quarter of this year. Gone. Hopefully you can still hear me. Focusing on those with highest ongoing needs, and we know frailty and some of our persons who are in their last 12 months of life really need that support critically. So that will be the sole focus. So Helen, did you want to come in and talk specifically about what the, and I never get the acronym right, so I'll say the whole thing, Pan Sussex Palliative and End of Life Care Programme Board.
Group.
Group.
So this was a group that was set up in 2022 after palliative and end of life care was recognised as a priority work stream within the ICB. Although it's coordinated by myself and my team in the ICB, it is an ICS, a whole system oversight group with representation from everybody bar a carer hub at the moment, which we're working on to address that gap. So as it says, we meet roughly every 2 months. We cover a wide range of topics, so any organisation can bring any particular topic they would like for discussion, review, consideration. One of our, well, close to my heart, successes was the subgroup that came out of that has created the Pan Sussex documentation around end-of-life care medication, prescribing and administration, which has had a huge positive impact in ensuring that medications are in place in time for people in their own homes to support a good death. So that's an ongoing group, which David is part of. In terms of the Respect, again, we started rolling out Respect across Sussex back in 2020 or slightly earlier in East Sussex. We know we still have a long way to go. The uptake is increasing. And in fact, just today at lunchtime, we had a multi-system group with CMOs from various organisations across the system, again, to discuss how we can improve on the numbers of Respect plans and how they are used across the system. I'm quite happy to take the rest of the slide, or I'm happy to pass back to David, because I think Tanya's already covered the last bullet point.
Thanks, Helen.
Did you want to? I was thinking you would carry on, Helen. Sorry, is that Respect and all, because it's all very ICB, or don't mind?
So I think the Respecting Faith and Culture End of Life Care Handbook is probably self-explanatory. This was actually a piece of work that was built on something that had been done in Frimley ICB. One of my colleagues in the Population Health Management team at the ICB coordinated tailoring that to a more Sussex approach. And again, that's available on the intranet so that anybody working in health or social care can access that electronically. It's also been shared as a PDF widely across NHS organisations, social care and the hospice sector.
Thanks, Helen. And sorry, I should have introduced you earlier, shouldn't I? So that was Helen Cobb, Senior Manager, Community Commissioning and Transformation, working on palliative and end-of-life care across Sussex. So thanks. Next slide, Giles. And this is the last slide. So this last one is just support for families, carers and the bereaved will be enhanced. And these are a few of the sort of things going on. There is a fairly new Sussex Bereavement Support Forum, which started in West Sussex, but has now been expanded across Sussex, facilitated by Public Health. and is to promote and encourage collaborative working, ensuring that the bereavement needs of different groups are met, and to identify any gaps and reduce inequalities in bereavement support. So we invite bereavement providers and other people working in that space to attend and discuss different topics each time. So the next one is mid-October, and it focuses on mental health. Next week, we got Rethink Mental Illness, which is a service that provides bereavement support for adults bereaved by suicide in Brighton and Hove. And that is currently accessible through the UOK Mental Wellbeing Service. And then Winston's Wish, which is Sussex-wide, but providing the same kind of bereavement support to children and young people bereaved by suicide. We also have Cruise, national organisation operating in the city. And then there is a web page on the council website, which has a list of bereavement support resources. I think the link is in the report. And it's a local online resource to find support after the death of a loved one. So we're always trying to kind of push that out, promote that and raise awareness of it and keep it up to date, more importantly, like all of these web pages. That's the last slide. Thank you, everybody. Any questions?
Thank you, David, Tanya, and Helen, for the report. Do you have any questions? Yes, Councillor Isaac Saman.
Thank you. I got two questions for you. Do you know what is the percentage of people dying at home or in a place they choose are for people of different faith and ethnicities? And my second question, are there barriers related to ethnicity or faith that make it harder for people, our community, to experience a good death? Thank you.
Thank you. I think in answer to the first one, it's national data, and I don't think we have it broken down in that way. There is some work at the moment on a needs assessment, which is just starting up on palliative and end-of-life care needs. So I think those are the kind of questions we can look at and see if that data does exist locally and pull it out. So, and in terms of barriers, yeah, I wouldn't sort of like to say myself what those barriers are, but I think having the handbook that has been produced, you know, is a good start in terms of, you know, this is being rolled out to health and social care staff and making them aware of different beliefs and faiths and what people would want to make it a good death for them. So I think there is work underway to kind of do that. I don't know if, Tanya, if you had anything to add or...
Thanks, David, and thank you for the question. I think the handbook has come to light because we recognize that it has not always been the good experience that we'd want many communities to have. In terms of the data, there is not a lot of data at the time that we brought the handbook into that we segmented or broke down to the different ethnicities. We do, however, have data associated with those who die in hospital, which isn't their preferred place, and we have that broken down into ethnicities. So I think we would be able to get some local data, certainly for Brighton and Hove. The dying at home is slightly harder, so I'd probably lean to Helen to say whether we've got any of the hospices would perhaps have some data. And we may need to take that away and think through how we would accumulate the two sets of data, those that are dying in hospital, where it may or may not have been their preferred place, but also those that are dying whether in hospice and or at home being their preferred place. So we could certainly take that back. I don't know, Helen, if you wanted to add to that.
So historically, ethnicity hasn't been recorded by hospices, but I think that's a reflection that historically ethnicity and culture hasn't been brilliantly recorded across any parts of the system, but certainly it's something that we have talked about, and it's something that hospices would be keen to capture going forwards.
Thank you.
Thank you, Councillor Asad Zaman, for that question. I think that was an important question as well. Do we have any more questions? Yes, thank you.
And mine's just a comment, really. Just we can't draw direct correlation to why Brighton's higher, but I know over the last year we've been, as a Brighton and Hove Federation, we've been working really closely with SCFT on the virtual ward, and that is a big part of that is supporting people to get out of hospital and really help the transition from acute care into palliative care. So can't claim it's a direct correlation, but I know that that's definitely should be moving in the right direction.
Thank you. Yes, Stephen?
Well, first of all, thank you for bringing a really important topic to the board, actually, because it's the only certainty in life is death. And I think a good death is really, really important. So thank you for bringing this to our attention. I've got two questions that are not related in any way, but I think the first is related to your comment about hospices. We certainly in this area, you have 1% versus the national average of 5%. And we've got some brilliant hospices in Sussex. And I've not visited them all, but I've visited quite a few of them. And I just wonder what else we can do to actually address that, because actually the hospice sector for some people is a really good place to die, and to allow them to have the good death that everyone frankly deserves. And then the second question is related to the earlier paper. And I'm sorry to say I don't know, but for those people who are homeless or rough sleeping, how do we identify what a good death would look like for them, and how do we support them? Now, we may or may not have the answer, but I'm trying to link the papers together, because people who are homeless or in temporary accommodation also deserve a good death.
Yeah. Yeah.
Can I jump in?
You can. Yeah. Do. Sorry.
Thank you. Was that Stephen that was asking the questions?
Yes.
Yeah.
Okay. So first of all, Stephen, you may be aware that in April we brought a paper to HOSC, Brighton and Hove HOSC. Whilst I was developing that paper, I was quite surprised by the figures that were being presented by Fingertips regarding Martlett's inpatient unit. I've been monitoring their activity twice weekly for the last 5 years, and it just didn't match from my experience. So I did reach out to Martlett's, and we did a robust piece of work that did demonstrate that the figures being presented by Fingertips are a huge underestimate of the number of patients that are being cared for on the Martlett's inpatient unit. And in fact, the numbers were much higher, and they did match roughly along the 5% of the England figures. So just like to add some reassurance on that. The data is as good as the data that's supplied, and it clearly wasn't great in that case. In terms of the homeless and end-of-life care, I'm afraid I don't have the details of it, but certainly within the last few years, SCFT worked with Martlett's Hospice to do a specific project around providing palliative and end-of-life care for those that find themselves homeless. It was very successful. It was published and awarded. I'm afraid I don't have the details, but if you'd like me to go away and find that for you and share it, I'm more than happy to.
Great, that'd be really helpful, Helen. Thank you very much. And it's good to hear about the data as well. Thank you.
No problem.
Thank you. Any more? Okay. Can we have a question from Nigel?
Thank you, Chair. Hopefully you can hear me okay. This is a question for both Helen, and a comment really, and David. I wondered whether you were aware of the Good Grief Hastings Festival that is due to take place in May next year. So it's part of a national 2.4 million project funded by the AHRC, the Arts and Humanities Research Council, and it started from Good Grief Weston a few years ago, which is a festival that sounds very similar to the Dying Well Week that you've talked about. So it's a festival that covers dying well, grieving well, loss and love, and it includes things like performances, art, film, dance, so on and so forth. So it's a very, very strong creative aspect to it. But it's being led by St Michael's Hospice, based in Hastings, in collaboration with 18 Hours, which is are a company that organised that help organise festivals. Together with there'll be a Good Grief Weston-super-Mare, a Good Grief Blackpool, and a Good Grief Hastings, all happening during the year. And a significant part of this particular work is about adopting and developing a systems-wide approach for this, not just to be one-offs, but to be continued in, over the years. So it feels like a really good opportunity here to potentially link these initiatives between Brighton, Hastings, Blackpool, and Weston-super-Mare. So it was just, are you aware of that? Is it of interest? And if so, I'd be very happy to talk to see whether, we can do something. Thank you.
Thanks, Nigel. It is of interest, so yeah, I'll follow up with you. And the link with creativity is really important, I think. 2 years ago, Brighton University also did a kind of grief festival. It was in November. They had a whole series of talks, performances. Anyway, I'll follow up with that.
Super. Thank you.
Okay, thank you. And yes, can I have?
Thank you, Chair. Just a couple of things from me. Not so much questions, more comments. First of all, I have had a sector colleague approach me in advance of today's meeting, basically asking the same thing as the councillor did about a different community of identity, specifically the LGBTQ community, and whether there was data available. So if there is hospital data around dying at home versus a hospital that's available for that community as well, my colleagues would be interested in that if it's available. And my other thought is really one for us all to consider as a board, really. It's interesting to see the dying at home data being brought to this evening's meeting. I think that being set as something to track was something agreed by a previous administration. And I just wonder if it's the time for us, we could take it outside of the meeting perhaps, but a time for us, Chair, to think about future targets that we would like to track in relation in particular to the 4 wells when we bring up items like this to the agenda, or whether we want to continue to track the deaths at home or whether we want to look at other things. And earlier this evening, Stephen made the good point on the Let's Get Moving item about whether or not we could be setting targets in addition to comparative studies between local and national data. So maybe there's something for us to think about for future board meetings.
Yeah, thank you for.
Just a slight response to that, we are exploring the refresh of the joint health and wellbeing strategy and what that might look like. And I think that's a really good opportunity to start to pull in some of these different questions as we move beyond the pandemic. Obviously, the original strategy was a pre-pandemic strategy, and it's very much time to reconsider that. And I think these are all good questions to explore.
Yeah, thank you, Carolyn. I think we've got some sector colleagues who'd be very interested in engaging with that process, including some that are new to the city and stuff, so they've sort of expressed that interest.
Okay, thank you. So do we agree there's something which can be arranged between you? Yes? Thank you. Any more questions, comments? Right. Does the board agree to note the report? Then I call this meeting to an end.